All right, everyone get their homework assignment turned in, I hope. Hopefully no one's like, there was a homework assignment? I hope not. Everyone can see the course now in Canvas, correct? Fantastic. And did you guys see the sticky board that you go into? There's a link on Canvas that says farm, intro to farm, whatever it is, sticky board. Click on that and you'll get to this site. And you'll be able to post anonymous little post-it notes, and you can ask questions if you feel like you may not be brave enough to ask in the middle of class. I still encourage that just because it's a good open discussion. I'll talk about them at the end of class, so anyway. And you can write any messages you want. I'd recommend keeping them civil, and if you can. I've not had issues with that before, but you never know, right? Never say never. Any questions from stuff we covered last week? Yes, ma'am.
Would you mind going over the up and down regulation and then when we talk about enantiomers,
Mm-hmm.
does the efficacy and potency change between those or?
Yeah. So last question first. So potency may change. So as an example, we talked about albuterol, which is an inhaler used for asthma, versus levalbuterol, which is the left-hand version. The potency may not necessarily change, even though the dose changes, right? So as an example, 5 milligrams of albuterol is equivalent to 2.5 milligrams of levalbuterol, which is just that left-hand version of that. I don't know that the affinity specifically changes. There may be a little difference between the left and the right. Clinically, it doesn't really come up all that too often, right? Um, and then in terms of up and down regulation, right? So again, think about the body always wanting to maintain homeostasis, right? So again, if I turn up the heat in the room and you guys get really hot, you're probably going to want to take off your jacket, or you're going to want to start sweating, right? If I make it really cold in here, your body's going to start to shiver in order to get the temperature back up. So there's always counterbalances to any change you make in the body. Same thing with drugs. If I were to go ahead and introduce a drug which is an agonist and I'm overstimulating those receptors, how is the body going to respond to that? Well, it's going to say, well, I want less activity. I'm going to get less receptors, so that way the drug can't interact with as many of them, right? So ideally, you get less effect out of that. If I were to give an antagonist and I were to introduce that to the receptors, and they say, wow, I'm not really being activated enough. Well, how can I get more activation? I get more receptors. You would upregulate those numbers in order to be more sensitive to it, right? And that's important because if you have, say, sudden withdrawal of a drug, you can have withdrawal effects because of the up or down regulation there. I mentioned that severe hypertension you could get if I were to take away an antagonist very quickly, right? If I were to withdraw it and the patient would stop that. And there's been cases of people who have had a heart attack because they were chronically taking a drug, they stopped taking it, and then all of a sudden that upregulation that happened there caused them to be severely hypertensive, tachycardic, heart needed too much oxygen, didn't get enough to it, and then they had a heart attack, right? That make sense? Mm-hmm.
So if you're separating them, I'm assuming that the cost of the drug is going to increase significantly.
Well,
and the effectiveness doesn't really change. So
it depends, right? So it's on a case-by-case situation. In some of these cases, we don't know what the actual difference is, right? The reason why the cost goes up is because now you have a new chemical entity that you're trying to market and you're trying to sell, and you have to get a new patent on that. Right, so as you get a new patent, you go through the FDA and they give you that. Now you have a new patent to make money off of that, right? So that's why you do get a new brand name product. So as an example, cetirizine or Zyrtec, it was going generic and it went eventually over the counter, and they were like, well, and I can't say this is what was in the hearts of the people that are actually doing this, but what it seemed like is all of a sudden, next you have levocetirizine came out, and it was like, okay, well now we have a new brand name product. So that way, imagine if you were working at an office and you have the drug rep come by and they're like, hey, why don't I take you out to lunch? Let me talk to you about this new drug. It's the greatest thing ever. They may not have any studies to actually show that, but you're like, man, that was a really good dinner I had, or a really good lunch I had with that drug rep. I'm gonna go ahead and go start writing for that. Or they give you samples and you start using that, and then you write scripts for it, right? So again, it's not like they're trying to manipulate you to some degree, right? They're just trying to get you to use their drug.
Well, is it possible that they're also going to decrease the side effects that can happen?
Possibly, right? But again, we may not know that. We may not know specifically that's going to actually happen or not. They may have studies that showed that to be the case, and if so, that is great, right? I'll give you an example with albuterol and levalbuterol. They did the studies together, and they were comparing the two together, and they said, wow, look, levalbuterol causes all the less side effects. But they really weren't using an equivalent dose. They were using 5 milligrams of albuterol compared to 1.25 of levalbuterol. Well, that's not an equivalent dose. You need 2.5. And maybe if you had upped that dose, you'd find similar side effects. So sometimes we just don't know the answers to that, right?
So that's not the reason behind it.
Yeah, ideally that would be the nice thing to do, is to get the one enantiomer that causes all of the good effects and none of the bad effects, right? But we may not be that cut and dry. Mm-hmm. Yes, ma'am.
As far as like
going easy on like the liver, is it better to have a dose that's maybe a bigger, like more of a dose but less potency, or a smaller dose with more potency, or does it not really matter?
It doesn't really matter, right? So just because you're giving a drug to the liver doesn't mean it's causing harm necessarily, right? So I mean, the liver's made to detoxify. That's what it does, right? And it's very good at repairing itself. You can find people who have fulminant hepatic failure from an acetaminophen overdose, and they can have full recovery, right? So the liver's very good in that sense. I kind of think about it like a lizard's tail, like if you like have a lizard's tail get chopped off and grow back, like the liver is very good like that. So to that extent, you may find that the dosing has been sort of figured out already by the drug companies and by the studies to determine what is the correct dose to make sure that we're getting maximal efficacy without causing a lot of toxicity. Some drugs are just hepatotoxic. We just know that, right? So if you've ever heard of Depakote or valproic acid, it's an anti-epileptic. We use it for bipolar disorder. It is a known hepatotoxin. We know, and that's why we monitor for it, right? We monitor LFTs to see, do you have toxicity from that or not?
Okay.
Any other questions? This is great. I like when you guys have questions. It shows you're engaged a little bit better. Yes, ma'am.
Just to kind of clarify the up and down regulation, so basically what you're saying in a nutshell is the body will create or not create receptors based on what it needs for that given medication?
Yeah, essentially, yeah. It's just a natural response you'll find in some cases, right? And it may or may not be clinically significant, but in some of those cases, I'll talk about that when we get into Farm 1 and 2. I'll talk about those cases where that is clinically significant, where you could potentially, really harm somebody if you were to have them withdraw their drug all of a sudden. Yeah. Cool. All right, so getting into talking about secondary messengers and dose responses. Now, we've already talked about first messengers, right? That's our drugs, that's our hormones, that's anything that's going to be binding to those receptors that we talked about before. We had 4 main types of receptors. What were those? Anyone remember? I had the ion gated, right? So again, if you have those open up, ions flow in or out, depending on what type of ion channel it is. Good. What else? It's G protein receptors, right? What else? We have the enzyme-linked receptors, like the tyrosine kinase. That was the most clinically important one out of those. And then what was the fourth one? Those are the intracellular. That's where a lot of hormones work, like thyroxine or insulin, things like that. They may be working at the actual, not insulin necessarily, but think about estrogen, testosterone. They're going to be working those intracellular sites on the nucleus, right? So let's talk about the secondary messengers, the secondary steps that happen in order to have the effect that you're looking for, right? So I can have a drug interact with the receptor on the actual cell surface. What happens after that, right? What are the secondary steps that occur that allow for your blood pressure to change or your blood sugar to change or whatever the case may be? And then we'll talk about dose response a little bit later, how we respond to medications. So as I mentioned, these are going to be the relay molecules, essentially. They go from the receptor down to cause whatever effect we're looking for. Common ones you're going to run into include things like cyclic AMP, right? Adenosine monophosphate. You guys are familiar with ATP, correct? Adenosine triphosphate. What do we use that for? Energy, right? So you're going to find a lot of these are energy-dependent sort of reactions that will utilize phosphate in order to form some of these products like cyclic AMP, like cyclic GMP, guanosine monophosphate, and then actually calcium is a really strong signaling molecule as well, right? Now, where do we keep a lot of calcium within our cells? Within the bone, but not necessarily the tissue, but what cell structure normally contains a lot of calcium? You guys remember the sarcoplasmic reticulum? Remember that? Remember going back to all those organelles back in biology way back in the day, right? So there's a lot of calcium we have stored up within our cells itself, and they can be very powerful signaling molecules, and we'll talk about those a little bit later, right? And that's how our muscles function, right? If you didn't have calcium within your skeletal muscle cells, you wouldn't be able to move because that causes the actin-myosin to interact and all that good stuff. But anyway, these can be activated, again, by either enzymes. They can be activated by ion channels, changing the actual electronegativity of a cell potentially. There's a lot of ways this can occur. I will give you specific examples of how these secondary messengers make sense in a clinical perspective in relation to specific drugs. So cyclic AMP, this is actually formed from the enzyme adenylyl cyclase. If you see AC, that's what that is referring to in ATP, which we said is a high energy molecule used for lots of things in the cell. And we have cyclic AMP targeting protein kinases. When I say kinase, what does that mean? It's an enzyme, but it phosphorylates, right? It's going to add a phosphate group to something. Remember when we were talking about the tyrosine kinase receptors, and once those got activated, they had those phosphate groups attached to it, those high energy phosphate groups. That's a kinase that was doing that. It's a tyrosine kinase receptor. So just when I say that, that's what I'm referring to. But anyway, let me give you some examples of hormones that actually work through the cyclic AMP pathway. We have things like ACTH, which is adrenocorticotropic hormone. Anyone know what that stimulates? Eventual release of things from the adrenal gland like cortisol, right? Talk about things like glucagon. What does that do? Raises blood sugar up, good. Talk about TSH or thyroid stimulating hormone, and then finally vasopressin. Another name for vasopressin is antidiuretic hormone, or ADH. What does that do? Stops you from urinating, right? It's antidiuretic hormone. Hold on to fluid, right? It has a big effect on water balance in the body, has a big effect on sodium in the body and whatnot. These are very important hormones we're going to be dealing with. So just to give you an example how this works, looking here at this picture, you have your hormone, which is going to be that first messenger, is going to bind to that receptor. Now again, remember this is a G protein here, so this is a G protein receptor that it's binding to. Again, don't get bogged down in all the details here, but eventually what happens is that G protein will activate the adenylyl cyclase. That will then cause this conversion, and then you have active cyclic AMP formed. That will then activate these protein kinases, and then downstream you're going to have whatever effect occurs, right? Whether it be changing cell transcription factors, changing protein activity, whatever the case may be. So that secondary messenger, that cyclic AMP, is what's actually causing the cellular effect, right? So it's causing that change that's occurring there. So as I mentioned, this has a lot of effects on different hormonal responses. Like I mentioned, glucagon will help to mobilize glycogen stored within the liver and turn that over into glucose, right? What's that process called? We break down glycogen. Well, if you're breaking down glycogen, that's glycogenolysis, and then when you form glucose from that, that's gluconeogenesis, right? So again, that is one of the things that glucagon will do, will help to stimulate that process. We'll talk about conservation of water with vasopressin in the kidneys. We'll talk about calcium homeostasis, which is really important with the parathyroid hormone. The point is that these are all examples of things that use cyclic AMP as a mediator there, okay? Again, it's good to know that the adenylyl cyclase is the enzyme that will form that cyclic AMP, okay? Again, we'll look at effects of epinephrine and norepi in the body as well. Okay, so here's an example. Now this looks really complicated, and it is, but let me tell you specifically what I want you to take away from this. Now this is what epinephrine, and again, where does your body release epinephrine from? The adrenal glands, right, primarily. And so what you're going to find is that epinephrine is going to go and it will interact with this receptor here, right? So it will activate adenylyl cyclase, and then now I have my cyclic AMP, okay? Cyclic AMP is my secondary messenger, then activates these protein kinases, and you have a bunch of stuff in the middle, which I'm not so concerned about. But what is important is you have liberation of glucose here, right? Now, why do I need glucose in response to epinephrine? When do you release a lot of epinephrine? Say like a bear popped out at me, I need to run away. That's my fight or flight response, right? So that's epinephrine getting released, part of my sympathetic nervous system. I need energy to run away from that thing or fight it or whatever the case may be, and so that's where the glucose comes into play. So again, think about that sympathetic, parasympathetic nervous system. Those are really, really important to understand in terms of how drugs are going to be working. I'll try to hammer on that as we go through these examples here. But again, just know that this is cyclic AMP being formed, activate these protein kinases, and that will eventually have my effect that I'm looking for, which is glucose production, leaving the liver, and thus I have more energy to send to the skeletal muscles, so that way I can run away or fight or whatever I want to do in that case there. Another example in the kidneys here. Now again, what is this? With this is the nephron in general, right? So again, here you have the glomerulus, your proximal, convoluted tubular, loop of Henle, your distal. Again, we'll talk about that later. We have a whole renal section. We'll talk about these medications that affect this. But the important thing I want to focus on here is that you're having adenylyl cyclase activate cyclic AMP and putting in some of these aquaporin channels, right? Aquaporin channels allow for water to be reabsorbed from the collecting ducts within the kidney, and that makes your urine more concentrated. That's important for helping us to balance water, balance salt within the body, and so that's an important factor there to remember. In ADH, you can actually have disease states where you're releasing too much ADH. You can have drugs that inhibit ADH release. Is anyone familiar with, again, I always go back to alcohol because I think it's a pretty ubiquitous sort of substance in society. Have you ever heard the term like breaking the seal when drinking alcohol? What does that mean? You have to pee a whole bunch, right? Anyone know why you have to pee so much when you drink alcohol? Because it inhibits ADH release, right? So you don't insert all these aquaporin channels, which means you keep much more water in the collecting ducts, and thus your urine volume goes up pretty significantly. That's why you get dehydrated, right? So again, it has to go back to that cyclic AMP not being formed there because there's no ADH to stimulate that process, okay? In the heart, here's an example of a sympathetic nerve being used to release norepinephrine. Again, this is part of that sympathetic nervous system response onto beta adrenergic receptors. Remember, when you're thinking about sympathetic nervous system, you think about beta receptors, think about alpha receptors. On the heart, anyone know what type of beta receptor you have? Beta 1 or 2? It's beta 1 actually, right? The way I think about it, you have one heart, you have two lungs. Beta 2 receptors are pretty predominant on the lungs. Beta 1's mainly on the heart there, right? So that's how I think about that. But anyway, you have beta 1 receptors here being activated. That will then lead to cyclic AMP being formed, and this allows calcium to come in. As I mentioned, calcium is a very important molecule to help with cell signaling. It also helps with contraction of the heart, right? Because again, the heart's a muscle. Calcium helps with having a stronger contraction, increases the speed of the heart. So that way, when I'm having that sympathetic response, I can run away because now I'm pumping more blood, more oxygen, more glucose to my cells, right? Again, these are just examples of how cyclic AMP is being used to cause pretty dramatic effects within the body itself. Okay, cyclic GMP is used as well, maybe not quite as ubiquitously as cyclic AMP is. And in some cases, you may actually find that multiple secondary messengers may be used in concert, right? Sometimes they may be antagonistic to one another. Sometimes they may be helping one another out, as the case may be. You'll find cyclic GMP is used quite a bit to help with smooth muscle relaxation, right? That can include smooth muscle in the GI tract. That can lead to smooth muscle relaxation around the vascular smooth muscles. That way it can affect blood pressure pretty significantly. And so this is good because if I were to relax the vascular smooth muscle, that can increase blood flow to certain areas. And I'll talk about a good example of that in just a second here. So here's a smooth muscle cell here. And then again, imagine I were to have an agonist activate this guanylyl cyclase, right? Guanylyl cyclase is the thing that forms cyclic GMP. By forming cyclic GMP, this is then going to lead to some downstream effects where basically I'm going to be inhibiting calcium influx into the cell. By inhibiting calcium coming into the cell, that means less smooth muscle contraction, which means this muscle cell is going to then relax, okay? Which is good. That can help to lower blood pressure. It can also lead to certain side effects. So what would happen if I were to, say, inhibit the smooth muscle in the GI tract and I were to stop peristalsis? Get constipated, right? You find a lot of drugs that can actually do this can lead to constipation because they're relaxing that smooth muscle within the GI tract and causing it to not contract as well, okay? Has anyone ever heard of the drug sildenafil? You know what that is? Viagra, right? What's Viagra used for? It's for erectile dysfunction, right? Now again, what's a primary cause of erectile dysfunction? We have decreased penile blood flow. Well, there's different ways to interact with the system here. So imagine I can give something that actually stimulates directly cyclic GMP formation, but what if I inhibited the breakdown of cyclic GMP? That's exactly what this drug does. It inhibits an enzyme called phosphatidylesterases, PDE5. By inhibiting that, I have more cyclic GMP around, which means I get more smooth muscle relaxation, and that leads to increased blood flow, and thus you can get an erection. Right? So there's different ways to affect the system there, right? I can either be a direct agonist or I can affect the breakdown of the secondary messengers, okay? And again, I'm pointing out these specific examples not because I want you to memorize every single one of these drugs right now, but I want you to start to see kind of the bigger picture of like, oh wow, there's different ways to affect the system, and medications can come into any one of these steps here, okay? Another really good example of something that will help stimulate cyclic GMP is the drug nitroglycerin. What do we give nitroglycerin for? You have chest pain, right? Some people say angina. I say angina. I don't know. One year I remember I had some students and I said angina, and they were like, we say angina. And I said, well, I mean, you know, potato, potato. And so, well, like only you and like the cardiology guy say angina. I say, well, if the cardiology guy says angina, wouldn't you want to say angina? Anyway. Either way, I say angina. But so yes, we give this in cases of angina. Angina is basically what? It's chest pain. Why do you get chest pain? You may have vasoconstriction, maybe due to blockages. Essentially, you're not delivering enough oxygen to the heart, right? Demand is outstripping supply. Well, I can try to give a medication that will cause smooth muscle relaxation that will help with that to get more blood flow to the heart, and thus you have relief of that chest pain, okay? So imagine you're having someone having chest pain, right, like this guy here. You'd give nitroglycerin. Anyone know how you give it? Like what route? There's actually a sublingual, yeah, there's either a sublingual tablet or there's a sublingual spray. I can also give it IV, but let's say we're in the outpatient setting and someone's taking this themselves. This actually gets converted into the product called nitric oxide. Now it says not the same as nitrous oxide. Anyone know what nitrous oxide does? Laughing gas, yeah, we actually use it as an anesthetic for surgical procedures and things like that. It also makes your car go really fast, as it turns out. But nitric oxide is what we're using here, and this will activate the guanylate cyclase enzyme, right? By activating that, you get more cyclic GMP. That will then cause smooth muscle cells to relax on the coronary vessels, and that allows for more blood flow to go to the heart. Thus, you get more oxygen. Thus, you have relief of that chest pain. Okay. So again, this is how the secondary messenger is coming into play. Here, we're actually giving a product that directly gets turned into the thing that stimulates that process. Okay. Now, calcium, again, is another very important signaling molecule, as I've already mentioned. Sometimes it works in concert with this thing called IP3, or inositol triphosphate. You can see calcium is probably used even more widely than cyclic AMP, right? It's very, very important for different things like neurotransmitter use, growth factors, all sorts of things here. And by increasing calcium influx, you can lead to things like more secretion of substances, like, for instance, by increasing calcium influx into pancreatic beta cells, that can cause more insulin to be released. Can cause muscle cell contraction, right? You can actually cause, things like, increased peristalsis if I were to increase calcium into the GI tract, things like that. And it can also affect things like cell division. We'll find IP3 is mainly used to try to mobilize those internal stores of calcium. I'll show you a diagram here in a second, but think about that endoplasmic or sarcoplasmic reticulum holding on to all that calcium in our cells. So again, here is a non-skeletal muscle cell, and so it's going to have an endoplasmic reticulum. And if you would actually measure the amount of calcium within the cell itself, it's actually pretty low, and because most of it's being stored up in this endoplasmic reticulum. But imagine here, I have a molecule come along, a first messenger, will activate this G protein, and I'm going to have this molecule here that gets turned into IP3 and then diacylglycerol, right? This is the thing you need to know about this. This is all going to lead to calcium being released from these cells here, or in the endoplasmic reticulum, and that's going to cause whatever downstream effect it is. Maybe it's releasing more insulin, a neurotransmitter, maybe it's stimulating cell division, whatever the case may be. But just know that IP3 and calcium are very important for causing these effects here. And so just to give you an example, like there's multiple ways you can affect this pathway here, right? So imagine here I have a vascular smooth muscle cell. You can see that there's many different systems that are all playing a role here, right? And medications can come in and affect any one of these, or maybe multiples of them. And this is why you can see that certain drugs may be synergistic when used together. Sometimes they may be antagonistic when used together, right? They may be fighting each other in terms of its effects. So as an example here, you can see things like angiotensin 2, Ang2. Anyone ever heard of angiotensin 2? Right? We give ACE inhibitors. Anyone ever heard of an ACE inhibitor? Lisinopril, we give that to prevent formation of angiotensin 2. This is a strong vasoconstrictor, right? It causes hypertension. So if I block that formation of that, I can thus get less hypertension, right? And the blood pressure is going to go down. I have epinephrine that can be released into the bloodstream from the adrenal glands, and that can affect beta 2 receptors. Now, again, you can find that even subsets of the same receptors can have antagonistic effects. So as an example, beta 2 receptors cause smooth muscle relaxation, right? So which is a good thing, causes hypotension. However, it can also affect alpha-1 receptors. Alpha-1 receptors actually cause hypertension because they constrict. So you can see how they can be a little antagonistic to one another. Just know there's a lot of different ways you can affect these systems here, and we'll cover all these different medications and how they can go into treat that. Because again, imagine you have a patient who's hypertensive. Can you always just give them one medication and it fixes their hypertension? No, right? Because again, every drug has its limitations, and every patient's a little different in terms of their pathophysiology. So I may need multiple medications, and it's important to understand how to mix and match those in order to get sensible combinations in order to maximize your effects, right? To get that synergy there. Okay, so these are important things we're going to be talking about as we go on. Okay, so getting into any questions on that so far? Okay, so let's get into dose-response relationships. So in terms of looking at drug studies, right? So imagine you're a drug manufacturer and you're running these clinical trials to try to get a drug out to market. One of the things you're going to be doing is trying to determine what the dose response is. Now, you on the clinician side, when you're out there and you're looking up drug dosing in your Terrascon or Lexicomp, wherever you look it up, this has already been done for you, right? So again, when it says, hey, give Tylenol 15 milligrams per kilogram, Q6 hours PRN. That's what has already been figured out based on this dose response. But I want you to understand sort of what's happening in the background to come up with this stuff, so that way you have a better appreciation for it. So why is this drug dosed this way versus another drug is dosed this way, even though they do the same thing? And so this is what we're going to be talking about here to some degree. So anyway, when you're doing these studies here, you can either look at how people respond in, say, a group of subjects, which is maybe what you find like a phase 1 or 2 or 3 trial, or you could be doing it in the preclinical setting and actually giving it to specific isolated tissues or organs, animals perhaps, in order to determine, well, if I give this much of a dose, how much effect do I see? And if I alter that dose, what effect change do I see at that point? Okay, and so again, this is that relationship between how much drug I'm giving and how much of a response I expect to get. So as an example there, if I give you 5 milligrams of lisinopril, which is a blood pressure lowering medication, it's an ACE inhibitor, I may get, say, a 10 millimeter of mercury drop in blood pressure. If I give you 10 milligrams, maybe I'll get 20 millimeter mercury drop, or maybe it's 15, or maybe it's 18, right? So this is what we're trying to determine when they do these sorts of studies here, okay? And this is really important, again, to understand the differences in terms of potency, efficacy, and all of that. And I'll show you some graphs and whatnot that will sort of illustrate that effect. So again, when you're testing a drug initially, some of the things you have to show that, one, when the drug isn't there, you're getting no effect, right? So if I were to give you a placebo, I shouldn't expect your blood pressure to drop at all, right? However, is that always the case? No, placebo effect is a real thing, which is why when you do like a double-blinded randomized controlled trial, placebo is sometimes used as that control to make sure that patients aren't having effects just from having the mental idea that, hey, I'm taking a medication that's lowering my blood pressure. I should have lower blood pressure. Mind over matter is a very important thing to consider there. So the next thing you must show is that by adding more drug up to a certain point, you should get incremental increases in efficacy, right? We'll find that every drug has a plateau in terms of the amount of maximal efficacy it can reach, but they should be able to show that. And then finally, by taking the drug away, you should get back to your baseline. Okay, so those are kind of the three things I want to show with these response relationships. And typically how these dose response relationships are going to look are going to be these curves here, right? So basically your response is going to be on your y-axis here. Almost said Y chromosome, that would be inappropriate. Y-axis. And then on your x-axis here, you typically have your dose, right? So as dose increases, you expect to see the response increase as well. And so you get these S curves that you develop here, right? And so again, you may find things may have very steep curves, may have very shallow curves, may have the curves may only go up a certain degree. All of it's going to be related back to the drug specifically. And I'll show you some comparisons between different drugs in a few minutes here. But typically, it will show this response here. Now, what do you think is happening when I'm kind of getting up to this point here where I'm starting to plateau out? What do you think is happening here physically? Full receptor occupancy, right? So I can keep giving more drug, but there's no more receptors for it to interact with, thus it has no more maximal effect, okay? So it's important to understand that there's a limitation to these, where just by increasing the dose further does not necessarily give me any more effect out of these drugs. That's important to understand. So again, the y-axis can really be anything. It could be enzyme activity, it could be membrane potential. They can basically set it to whatever they want it to be that they're looking for. Blood pressure dropping, blood sugar, whatever the case may be, they set that, okay? Now, looking at this, there's a few definitions to understand when looking at dose-response relationships. So here, the first one we have is ED50. This means it's the median effective dose, right? So this is the dose at which 50% of the population manifests a given effect, okay? So imagine if you were to take this curve, you administer this medication to a bunch of different people, that 50% point here is considered to be the ED50, okay? So when you're looking at that, you're like, well, is that enough for my patients, right? Is it enough that I only get 50% efficacy out of that? Maybe, maybe not, right? But the point being is that you can then use this ED50 to compare it to other medications, right? So again, this is good for comparison's sake, as I'll show you in just a minute here. But that ED50 is basically that midpoint of this S curve, okay? As I mentioned, there's a few parameters here with the curves that define its shape. So you have the baseline response, which should be the bottom, right? So again, it should be if you have no drug around, you have zero effect. That's what should be expected. The maximal response, sometimes we'll call this the Emax, the maximal efficacy that you're getting here at the top of the curve. Then you get the slope, meaning how dramatic of a change do I get in changes of dose, right? You may find that by changing the dose by just a few micrograms, you get huge differences, or you may find very small differences by changing by many milligrams or grams potentially. That will define how steep or shallow that curve is going to be, okay? And then the ED50, there's again that maximal, that half maximal effective concentration. It should be the midpoint between the E minimum, right, the zero response versus the E max, which is the maximal response, okay? And this is going to help us to determine the potency of a drug. And potency just means what? How much drug do I need to get in order to get the desired response? Do I need a little bit of drug to get the same response as another drug, or do I need a lot of it? And that's what we're going to be looking at, okay? So there's two ways we can look at these responses here. We'll talk about both of them. First one's going to be sort of a graded response. So it's kind of like, do I get a 2 millimeter mercury drop of blood pressure? Is it 8 or 10 or 20? That's going to be sort of a graded sort of response, right? So we're looking at various doses of a drug on an individual. We also have the Quantal dose response, and this is sort of an all or none phenomenon, right? So again, if I were to give you a medication that puts you to sleep and you were asleep, yes or no, right? Or if I were trying to do a survival study and I said you were alive, yes or no, right? So again, it's kind of an all or none sort of phenomenon. So there's a difference between these. One's sort of a graded, sort of how much of a response do I get, versus the Quantal is going to be yes or no, sort of did I get the expected effect or not. I'll go into detail on those. But again, looking at the graded dose responses, as you're going to find, again, that the concentration of the drug goes up, you should get more effect, and then it will plateau out once all receptors have now been occupied. And basically, you can kind of show it as this complex here, because again, drugs don't always just stay on that receptor forever, right? They're going to pop off eventually, and it's that equilibrium that you're looking at, right? So as I increase that concentration, you're more likely to have more of those receptors occupied, and that's when you get that maximal sort of effect there, okay? As I mentioned here, that response is a graded effect when you're looking at this graded dose response curve here. So it should be a continuous and gradual sort of change here. So imagine if I were to give you a continuous infusion of a medication, right? So I'm continuously infusing at a certain rate into the bloodstream. I can dial that up, and I should expect to see a gradual increase in effect. If I were to dial it back down, I should see a gradual decrease in effect. Okay, so it's all graded. It's that's how you get those that nice S sort of curve you're seeing there. Okay, and again, I'll show you the graph here in just a second. But again, this should be showing that relationship between the concentration of drug, the receptor occupancy, and then that magnitude of that physiologic effect that we're looking there. And so as I mentioned, that for any drug, maximum effect should be happening when you get full receptor occupancy. Half max response should be when half of them are occupied. Okay. So again, this helps us to really compare and contrast different drugs to determine, well, how efficacious is one drug versus another? How potent is it versus one another? And we'll show some comparisons here. But again, this is really helpful for both potency and efficacy. Now, when looking at a graph like this, remember, always look back to your ED50 as kind of like your anchor point for looking at a drug, okay? Now, how far to the left or right of the ED50 is on the graph shows you how potent the medication is. And again, as I mentioned, the dose is going to be on the x-axis here, so smaller doses are going to be closer to the left side, bigger doses on the right. So if I have an ED50, which is much closer to the left, that means I need much less drug to get that effect, thus it is more potent, right? When looking at efficacy, this is basically the maximal height of the curve itself. So if I were to have a less efficacious drug, it may be down here, right? If I were to give a more efficacious drug, it may be up here somewhere. So that is the point there. Now, clinically, what do you care more about, efficacy or potency? Efficacy, right? Because again, I can change the dose in order to get the right amount to get the effect I'm looking for. But again, if a drug is only ever going to be pretty minimal in terms of the efficacy, it's not a very good drug in the first place, right? So this is one of those things where efficacy for you guys is clinically much more important. But when you're looking at the dosing of drugs, especially when you're comparing dosing together of different things. So as an example, you may be looking at NSAIDs, right? We talked about NSAIDs last week, non-steroidal anti-inflammatory drugs. And we know like a typical dose of ibuprofen. So you may say like 200, 400, 800 is like the prescription dose of ibuprofen. Well, for a comparison to something like Toradol, right? Toradol is an IV NSAID that we might use 15 to 30 milligrams, right? So in that case, you'd say Toradol is more potent, but it may be getting the same efficacy in terms of effects, okay? So again, we've already figured out the dosing for you when you're looking up those references, but the efficacy is really what you're concerned about, right? Because again, you want drugs that are efficacious. Yes, ma'am?
So if you're introducing medication to a patient for the first time, do you kind of use that ED50 as like a starting point? Or
So
based on the patient's symptoms and how, like say blood pressure, say you're 140 as opposed to 160, do you still start at that middle point to see how much of an effect is everybody different?
Yeah, so that's certainly something we'll talk about a little bit later. So I will say, though, that you really won't be thinking about these curves. You'll kind of internalize it to a point to where like you're kind of thinking about, okay, where are they kind of at on the spectrum in terms of efficacy? But it depends, right? On every patient's a little different. Every drug's a little bit different there. In some cases, you may say, and imagine if you had a patient who came in with a fracture and their femur sticking out of their leg. Are you going to start off with like Tylenol, see how they do? Then, no, you're going to start off with like some heavy hitters because you know they're in a lot of pain, right? Versus something like blood pressure, Well, sometimes people have gotten so accustomed to that 160 systolic blood pressure that if you were to drop it too quickly, that would actually lead to a lot of side effects, right? Because their body's just used to that now, right? That's their new normal. So you can lead to things like dizziness and syncope and whatnot. So again, I hate to say it, but it depends is going to be a frequent answer that I'll give you guys, which is not satisfactory, but is the way of the world as it turns out. So, yeah, very good question though. But anyway, as I mentioned, potency just means in terms of milligrams, how much I need to get that desired effect. Again, this could be pain relief, it could be blood pressure. How do we normally quantify pain relief for patients? On a scale of 1 to 10, 1 being no pain, 10 being the worst pain you could ever imagine. What's your pain right now, right? Is it a very good scale? Is it objective? Not really. It's very subjective, right? So again, someone's 8 could be someone else's 4. The worst pain I could imagine is probably not the same with someone who's like given birth before, right? So again, it's not great, but sometimes it is a useful scale, at least, because that's basically the best thing we got. If you can come up with a way to get objective pain measurements out of a patient, you'll be a billionaire, right? You'll change the world. But anyway, as I mentioned, we're going to be evaluating this both on pain and potency and efficacy, as we'll see. So when comparing multiple drugs here, again, imagine you have drug A, B, and C. Again, these would be all considered equally efficacious drugs, right? Because their Emax is all the same. So clinically, I could use any one of these in order to treat my patient. I'd expect to get the same effect. The only thing that would differ is what? Maybe side effects, but more specifically looking at this curve, the dose I need to give in order to get that effect, right? So which drug would I have to give the smallest amount of to get the desired effect? Drug A, because it is the most potent, right? They're all equally efficacious, but it is the most potent. C would be the least potent, meaning I would have to give the biggest dose of that drug in order to get the effect I'm looking for, okay? Now, again, there's a lot of other things that come into play when you're deciding what drug to give to a patient. We mentioned side effects, talk about costs. There's a lot of different things that go into it, but just know that this has all been taken into account when you're looking at the dosing of drugs. They've kind of figured out what the equally efficacious doses are going to be based on the potency of the drug there. As I mentioned, in terms of opioids, right, I can give 5 milligrams of morphine, 5 milligrams versus 50 micrograms of fentanyl, maybe an equivalent dose, right? Fentanyl is obviously much more potent, morphine less so, but they're equally efficacious potentially, okay?
Question.
Yes?
The potency, just because it's less or more potent doesn't mean it has less side effects, right? Because one drug is...
Exactly, yeah. It's hard to say, right? You may have a drug that is super, super potent, but it causes a lot of side effects. You may have drugs that are not very potent that have no side effects or very minimal side effects, I should say. Every drug has side effects, right? But yeah, that has nothing to do with side effects necessarily, okay, for sure. Okay, and again, looking at this graph here, if you were to do, say, a rank order of potency by comparing the ED50s of these drugs, you'd say which one is the most potent? A, obviously, followed by B, C, and D, okay? Now, again, we talk about efficacy, that'll be a little different here in just a few seconds here, but again, A would be the smallest dose given to get the same effect as I would of, say, drug D, okay? So pretty straightforward. Now, as I mentioned, efficacy is basically going to be the maximal height of that curve. So how much a maximal effect should I expect to see out of this drug here, right? As I mentioned, agonists are going to have positive efficacy, meaning they should cause the effect I'm looking for by increasing the activity of that receptor. Antagonists should have 0 or no efficacy, right, because I'm blocking the effects, okay? Not to say that I couldn't put, say, for instance, give a blood pressure lowering medication and put them on a curve like this. I would just use my reduction in blood pressure as my y-axis there, right? So again, that would be the thing you'd be looking at. But again, you can find here that in this case, what would be the most efficacious drugs out of the bunch? A and C, right? You consider those to be equally efficacious, right? Equally efficacious drugs versus B and D, which would be less efficacious. Now, you may find that A and C may be full agonist, maybe B and D are only partial agonists, which is say, right? Or it may just not work as well as something like A or C will. So again, some of it is very dependent on the drug itself, how it's interacting with the receptor, what kind of effects you're getting out of that. But just know that the efficacy, again, is clinically more important than the thing we were concerned about. So, and again, you're going to find that the Emax is going to be that maximal dose we have to give here. And again, as you push that dose up further and further, remember that you may not get much more efficacy out of the drug, but certainly what could go up in frequency? The amount of side effects that you're going to be getting from that, right? So again, just because once I hit that plateau point, I keep giving more drug, you're just more likely to see more side effects, not whole likely to see more efficaciousness of the drug, because once you've hit all those receptors, you can't really get much more activity out of it than that. Okay. In terms of this, what do you think would be the most efficacious drugs? A and C, followed by right? Now B and D are actually different, right? So B is a little bit more efficacious than D would be. Now, for instance, it said, well, maybe I don't need all that efficacy. Maybe I don't need maximal effect. Maybe D is a lot cheaper. That could still be a good drug, right? It doesn't mean that it's not going to be not useful at all. It just means it may not be as efficacious as something else, okay? So you have to think about a lot of other things, costs, side effects, availability. You have to think all these different factors when going into drugs. But again, this is how we kind of think about it in terms, especially in the preclinical settings when they're trying to get the drug to market, how they're comparing these things together, okay? Okay, so getting into it, talking about the affinity and the intrinsic activity. Affinity just means what? We talked about that last week. Yeah, how much it likes that receptor, how much it wants to bind to it and to kind of stick on there. Again, high affinity means it really likes to be bound to that receptor. Low affinity means it has a hard time kind of binding to it. And then intrinsic activity goes back to, is it a full agonist? Is it a partial agonist? Is it an antagonist, right? So again, how much activity is it having to activate those receptors there? And again, that drug's action is going to be affected by, one, the quantity of drug that gets to the receptor, which again can have an effect based on bioavailability, which we talked about last week. If the liver is metabolizing a whole bunch of the drug, may not get to the tissue. It can have to do with the dose we're giving. It can have to do with the number of receptors that are available. A lot of things can affect that. But then once the drug gets to the tissues, how does it like to interact with the receptor? How good is its affinity to interact there and bind to it? Okay. So, and again, as I mentioned, that you can have agonists will have affinity and positive intrinsic activity, right? As I mentioned, they can have full or partial. Now, again, when would I want to use a partial agonist? Well, last week we talked about Suboxone or buprenorphine being good because it can help patients to wean themselves off of opioids, right? So that was a good case where a partial agonist can prevent withdrawal symptoms, but also help them to get off of their opioids, right? That's one thing it could be good for. Maybe you just don't need full efficacy. Maybe you don't need that high of an efficacy because I only have, say, a lesser problem to deal with. Maybe the blood pressure drop I need is not that great. I can use a lesser efficacious drug, right? So again, a lot of factors go into this here. But again, antagonists should have no affinity. I'm sorry, they will have affinity, but no intrinsic activity. They just bind to it, and they block other things from binding to that receptor typically, right? Those competitive antagonists that we talked about. Okay, so then getting into the Quantal dose-response relationships, this is where you get to the all or none sort of thing. So I like to think about this in terms of anesthesia. So are you awake or are you asleep? So if you're going for surgery, would you like to be awake or asleep? Probably would be asleep, I would imagine, right? Unless you're a glutton for pain, I suppose. But what you're going to find is that this is better for showing a population's response to a drug as opposed to an individual response to a drug here, right? So you're seeing how many people are reaching a desired effect, and that is going to be your ED50s when you get to that middle point there, right? So say I were to give 100 people a drug, and I'm looking to see it's a sedative, and I'm trying to put them to sleep, my ED50 would be the dose that I have to give to get 50 of them asleep, right? It's that ED50, how when 50% of that population has the effect that we're looking for, okay? And again, it's going to be plotted basically on the same sort of curve as we're going to see previous on the graded dose response curves, and I'll show you some examples of that. But again, the ED50 here is when you have 50% of subjects displaying the effect you're looking for. Yes, ma'am. Well, so you're talking about the dose you have to give? Yeah, so again, because every drug, when you plot it on a curve like this, will have we'll have doses below the ED50, we'll have doses above the ED50 there. But again, we'll talk about that in a second in terms of the effects you're looking for. But say, for instance, my threshold is like you have your patient go to sleep for surgery. Would you want to be dosing it at the ED50 or below? Well, no, because that would mean that a majority of the patients are still awake for surgery, and they're saying, hey, I'm still awake here, please don't cut me open, right? So typically you'll find that for these kind of Quantal dose response curves, you want to be well above that, right? You want to get close to 99 or 100% of your patients responding, because that means that the drug is working, right? So I'll show you an example of that in just a second here. Again, the ED50 would be the sedative dose that get 50% of the patients asleep, right? So as I increase that dose, more and more people start to fall asleep, and then once you get to that 50% point, that's the ED50 that we're looking for. Now, what would be the Emax? When 100% of the people are asleep at that point, right? So you can't get above that because you can't introduce like new people all of a sudden, right? You can't make more people fall asleep. I guess if you increase the dose so much that maybe the researchers were falling asleep too in the room because they're getting exposed to it. Who knows? But yes, ma'am.
So when anesthesiologist is putting someone to sleep, do they go with initial A dose or do they go by certain patient? Whatever works, I guess, for the patient.
Yeah. So yeah, let's talk about that in just a second. So getting into that, it depends. Some drugs will have kind of starting doses that you'll give. Some of it may be weight based, you know. Some of it may be based on concentration. So imagine you have like an IV drug I'm going to give you to knock you out, right? Like a propofol or something. I'll have like a starting dose that I give in order to try to knock you out initially, and then to keep you asleep, I'll use like an inhaled anesthetic, and I will dial in a certain concentration, right? And some of that is based on how much the patient's breathing in, how big they are, and there's a lot of different factors that go into it. But ideally, when you're using something like this, you'd want to dose it to where the majority of patients are going to be getting the effects that you're looking for. Because again, I probably don't want the majority of my patients to be asleep. Or say, for instance, you know, you're talking to your anesthesiologist before you're about to go back to surgery, and say, hey, I'm going to use a dose that has a 95% chance to put you to sleep. What would you say to that person? You may want to up your dose a little bit because I don't want to be in that 5%, right? It's 1 in 20 that are still going to be awake for that procedure there, right? So again, we've taken all this into account, but that's how they will compare drugs together, is by using these ED50s here, okay? Now, we also have another term called a TD50. This is the toxic dose 50. So this is when 50% of people would develop the toxic response that I'm looking for. And again, I can set that to be whatever I want. So as an example, say I was giving that sedative agent. The TD50, obviously the ED50 would be whether you're asleep or not. The TD50 may be, do you develop hypotension, right? So hypotension being defined as whatever I define it as, let's say less than, you know, systolic of 90 over, you know, 70 or something, right? Whatever I define it to be. That could be considered my TD50, okay? It could be considered something more severe, like maybe you develop metabolic acidosis or you develop respiratory depression or whatever the case may be. I can set the TD50 there. And so by comparing the ED50 to the TD50 and how close or far apart those are, I can start to determine how safe a drug is. And that's what the next thing we're going to talk about is. Now, most drugs and most substances will also have an LD50. What is that? That's where about 50% of the people are going to die from that dose of drug. Now, should you be dosing it close to the LD50? Not unless you're working at the penitentiary and that's your goal, right? You know, maybe not. There's actually some really interesting things with lethal injection about how kind of awful that process is as of late. But I'm not going to get into that. But basically, this is the LD50 is when 50% of those people would die. Ideally, your drug, the dose you're using for your patients would be close to the top of that ED50 curve, but far, far away from the LD50 curve, right? That's the ideal thing. Some drugs you may find is actually a little bit more narrow than you'd like, and those are going to be some more difficult drugs to use because they can be just inherently more dangerous. And we'll talk about that in just a few minutes here.
So we know that, right? We know what all those means, but we don't know what percentage our patient is in exactly, right?
Mm-hmm.
So we just figure that as we go.
Yeah, so you'll find that, and again, look at this graph here, right? So again, here I have my therapeutic effect, right? So here would be my ED50. So again, where I expect to get 50% of people getting a therapeutic response. Here's my toxic dose 50, where I'd expect them to get, say, a toxic response. And then over here, I get the LD50, right? So ideally, this would actually be a pretty safe drug in terms of whether I'm going to kill the patient or not. Because once I get up to the point where I'm getting 100% of the people getting the response I'm looking for, am I anywhere close to the lethal dose? Not really. But if you notice here, if I start to, say, draw a line, were to take this this line here and I were to say, okay, let me draw straight down, and again, I'm using a mouse, so this might not be super straight. Now, does that mean that no one that I'm giving this drug to is going to develop a side effect? No, some small percentage of those people are going to develop a side effect. Now, what if I had drawn, say, a curve? What if I get a different color? Let's say I were to draw a curve, the toxic dose 50 or the toxic effect line was more like this, say for a different side effect. Now, when you draw that line, you may find that much more people are going to develop that side effect, right? And that goes into the safety of the drug. And when I start to compare these lines together to see how much overlap there is between the therapeutic line and the toxic line or the lethal line.
How reliable would the lethal line be? Because what if you have like a relatively small sample size for that compared to like the ED50?
Right, so if you're doing a clinical trial, it's not like I'm going to take 100 people and say, okay, well, 50 of you might die from this.
Right.
So here we go, right? Like, they don't do that. How do they figure this out, though? Animal studies, right? They've done this kind of beforehand. So again, or we may develop this basically based off of anecdotal evidence. Say we've had people who've overdosed on these medications, and maybe based off case reports, we've determined that, okay, well, when you get about this dose, you know, you're probably pretty close to that LD50 there. So hopefully you never find out if you're anywhere close to that LD50 line. But sometimes patient conditions can change to where maybe that line gets a little bit closer, right? Maybe they're septic, or maybe they have a genetic predisposition to toxicity, and now that's moved a lot closer. Who can say, right?
Are the clinical trials like regulated? Do you need like a baseline, like a minimum?
Yeah. So when a drug company develops this, like they're going to do kind of the preclinical testing, so they'll test on animals and tissues and things like that. They'll take that info to the FDA and say, hey, we'd like to use this on people. And then the FDA has to say, okay, well, let's look at the evidence, let's look to see what you got, and then they'll say yes or no, that we think this is safe enough to try to give to people, right? And then that's when they start some of these trials here to get that idea of whether it's efficacious, what the kinetics are, and all that sorts of things. Yep. Mm-hmm. Okay, so let's go ahead and take a 10-minute break, kind of mull that over in your head a little bit. We'll come back and then continue talking about our dose response curves. All right, so there's one question on the sticky board so far. Thank you for whoever was the brave soul to use it. Well, see, you're brave enough to say something. You should have asked the question.
Well, I would forget. So.
Okay, that's good. All right, that's another good thing. If you have a question, and you're like, oh, I might forget this later, just put it on there. We can talk about it whenever. Yes, that's good. So what was the effect that Viagra has on cyclic GMP? It basically prevents the breakdown of cyclic GMP. So you have more of it around that you'd be producing naturally anyway in order to have its desired effect, which is to increase penile blood flow, and thus it's more easy to develop an erection. Right. Good.
Can you say that again?
Yep. So sorry. So Viagra will block the breakdown of cyclic GMP. So you have more of it within the cell. More of it is there to cause that smooth muscle relaxation. Thus you get better blood flow. We'll talk about that during the urology section, probably in Pharm 2 many moons from now. But so just keep that in the back of your mind. Anyway, so any questions from the first half? I know we're covering a lot of stuff, but this is basically kind of the foundation for everything we're going to do in Pharm 1 and Pharm 2. So understanding these concepts now is going to be good when you have questions like, well, why is this drug dosed this way versus this one dosed this way? Some of this will make a little bit more sense in terms of efficacy, potency, all these different things like that. Okay?
I do have a quick question.
Yes.
Like, does the curve always look like that, or could it be stretch more before it reaches high?
Yeah, so the slope of the curve is an important feature there as well, right? You could have something that has a very shallow slope to where it looks much more flat, or you could have something that looks much more steep, right? And so what that means is the steeper the curve is, the bigger the change you see with small changes in dose, right? So maybe I increase the dose by 1 milligram and I see a 10% change or something, right? Versus if it has a much more shallow curve, maybe I increase it by 1 milligram and I get maybe a 1% change. Okay, so that's what that slope is really telling you. So you could have a drug that has two drugs that have the same efficacy, that have the same ED50 essentially, but they may have different steepnesses of that curve there. The slope may be a little different, and thus you may find that means that you may need to have bigger changes in a drug to see kind of more effect, essentially. Okay. Clinically, again, it may not come up all that too commonly, but it's just something to kind of think about and kind of internalize when you're considering these drugs clinically. But getting into here, again, we talked about the therapeutic effect lines. We talked about the toxic effect lines. And again, that TD50 can be really any toxicity you're thinking about. It could be hypotension. It could be rash. It could be death, or death actually for the LD50. But really anything else that is considered a toxicity could be that TD50 line. Again, LD50 is just going to be for death there. Why that's important is what we can then do is develop what we call a therapeutic index. Okay. Therapeutic index is basically the ratio between either the ED50 in the denominator and what's going to be over that in the numerator is either going to be the LD50 or the TD50. Okay, either one of those. Typically, when you're looking at therapeutic index, it'll be LD50 over the ED50. Now, ideally, the LD50 is bigger than the ED50, right? If it was smaller, what would that mean? You're killing off your patients before you'd even see a clinical effect, right? So that's no good, right? Typically, you don't want to kill your patients, right? I should hear a lot of yeses, like, okay. Otherwise, you guys are in the wrong business. No. Or maybe you're in the right business to do whatever nefarious deeds you have in mind. I don't know. I don't know what's in your hearts. But, anywho, so to look at this therapeutic index here, right, this is basically how much overlap is there in these curves here, right? The less overlap, meaning I need to have a really, really big dose before I even get close to the LD50. That's a good thing. That means that is a very safe drug, right? That means it is hard to kill a patient that way, right? I'll give you some examples of this in just a few minutes. But again, having a bigger therapeutic index is a good thing from a medication safety standpoint. So we call this that margin of safety essentially, right? So again, if I was to look at the LD50 here, or say a TD50, and I were to look at this curve, again, by getting that maximal 100% response, hopefully it has no overlap or very little overlap. Now, the TD50 lines, we know there's always going to be a little bit of overlap in terms of which side effects you're talking about, because every drug has side effects. We just know it's going to happen, right? It could be as minor as something like, a little bit upset stomach. It could be as severe as, life-threatening electrolyte abnormalities. It could be, respiratory depression. It could be all sorts of things. But ideally, the more overlap there is, the more narrow that therapeutic index is, the smaller that ratio is, the more dangerous that drug is typically. So, and again, looking at this, and again, the therapeutic index is just TD or LD50 over the ED50. That's how we're going to get that number there. And again, I may ask on a test question, right? I may say, like, here's a few different drugs. Here are their LD50s and their ED50s. Which one of these would be the safest drug? And you'd pick the one that has the highest ratio, right? You'd want the one that has the highest difference between the LD50 and the ED50. Again, it'll be simple numbers. It's not going to be any kind of hard, difficult math, but as long as you can divide by easy numbers, right? Everyone can do a little simple division, right? I hope so. Might be hard on a test, right? You're a little stressed out, but you can do it.
Can you say that one more time?
All right, so say I were to give you a few different drugs, right? I'll give you different options, and I'll give you their ED50s, and I'll give you their LD50s. And I'll ask you, based off of those two numbers, which one is the safest drug? And so in your mind, you're thinking, okay, well, which one has the biggest therapeutic index, right? And so you divide the LD50 by the ED50, and whichever one has the biggest number, has the biggest ratio, means that's the safest drug. Or I can say which one is the most dangerous, and you would pick the one that has the smallest ratio, right? Would be a very good test question. I'm sorry?
Can you put that in numerical?
Yeah, so let's say, for instance, we have, let's see here. Again, don't judge me on my handwriting. It is going to be poor. I'm left-handed to begin with, and I'm also using my right hand on a mouse. So bear with me, please. And I can't even see my cursor here. So anyway, here we go. All right, so let's say we have drug A, right? And we're going to have the ED50 here. I'm going to try E. And we're going to have the LD50 here, right? And let's say, for instance, let's say 10, and this one's going to be 1,000. It's actually pretty good for me, right? You have B, and let's say this one is going to be 5, and this one is 50. And let's just say, for instance, we have C, and this is going to be, say, 6 and 600. Now, if I were to ask you on a test question and say which one of these would be the safest drug, you would say A, right? Because what's the therapeutic index? 100, right? So I would need to give a 100 times bigger dose of A to get to that LD50 than I would of these other ones, right? That's a pretty big margin of error, right? It's hard to give a 100-fold overdose of something. It's possible, but it's hard. Which one would be the most dangerous drug? B, right? Because that has only a therapeutic index of what? 10, okay? So that means it's much more easy to get that potential overdose. It might be easier when you're trying to get that patient up to that therapeutic effect you're really looking for. But you may have to sort of have some of that overlap there, right? Those are what we call a narrow therapeutic index drugs. Those are dangerous drugs that you oftentimes have to do things like blood level monitoring of. I'll give you some examples of that as well. We have a whole section on that later on. But be able to kind of look at these and assess, okay, well, which one of these are safest? Which one of these is more dangerous? Obviously, C would be somewhere in the middle, right? Actually, C would actually be equal to A, right? That would actually be equally, because, again, it's another factor of 100. Okay? That makes sense? Again, I was just using this stream of consciousness. But you get the point, right? A and C would actually be equally safe in those cases there. Okay? Everyone with me? I'm not trying to confuse you. I'm just going off the top. Could have been A or C, right? Now, again, when I read a test question, hopefully I will have thought more thoroughly about this, and I would not put 2 right answers. However, if you were to make the argument to me and say, hey, buddy, there's 2 right answers on here, and I would say, yeah, you're right, and I'll give credit for both, right? I always try to strive for fairness in things, and especially in test questions. I know it's a big deal for you guys.
Is it a low likelihood that we would see something that we could actually give our patients that would match B because it's such a narrow margin of error?
Potentially, yeah. I mean, potentially you could have, and again, a tenfold difference may be very likely, right? Once you start to get down to like 5, 4, somewhere around there, potentially, right? Because again, we have some drugs that are therapeutically necessary that may just have inherent toxicities to them. So as an example, look at a drug like a paralytic. Paralytic will stop all muscle function, right, including your diaphragm. If your diaphragm stops working, what do you stop doing? Stop breathing and you die, right? So if I were to give that to a patient who is we weren't breathing for them, say via a ventilator, it's very likely to kill that patient, right? And there's been medical errors where someone's accidentally given a paralytic, and that ED50 to LD50 is actually pretty almost right on top of another, because we know if we give it to the wrong patient, it will kill them, okay? But it's therapeutically necessary for people. So we intubate them, we ventilate for them, and it's a very safe drug at that point, right? Because then we're taking care of the very serious side effect. So that kind of make sense?
Kind of.
Very case dependent.
I was picturing FDA not approving that, but then if you're saying there's measures you can take and it's necessary, then it kind of has.
Yeah, absolutely. Yeah. So, and again, some of these are like old drugs that have narrow therapeutic indexes. I mean, a lot of drugs come from like really old school drugs. Where do they come from? Or like, yeah, herbs, plants. I mean, like aspirin comes from willow trees. I mean, you get digoxin comes from things. It's an antiarrhythmic, comes from things like oleanders and foxglove and things like that. They have a narrow therapeutic index, but they were good, and we still use them to this day for different things like CHF or AFib and things like that. We just know they have a narrow therapeutic index, and we'll talk about ways to get around that in just a few minutes here. But yeah, so yeah, there's some drugs we just know are really inherently dangerous. We try not to use them if we can, but it's just it's the way it is. Sometimes it's the only option you have in some cases. Yeah. So anyway, so as I mentioned, that therapeutic index is that ratio. Smaller is more dangerous, bigger is going to be better in those cases there. Okay. So, as I mentioned, it's preferable to have a high therapeutic index versus a low one. And just to give you a comparison, so diazepam. Anyone ever heard of diazepam or Valium? What is that? It's muscle relaxant. It's also anti-anxiety. You use it for a lot of different cases here, but this one has a very high therapeutic index. It's so the way someone described it to me is that the only way you could die from an overdose the class of drugs called benzodiazepines. The only way you could die from an overdose of a benzodiazepine by itself is if you got hit with the truck that was delivering it, right? Very safe, right? It's hard to kill yourself with just that because the margin between the LD50 and the ED50 is fairly wide. Versus something like digoxin, if I were to give someone the wrong dose, or if I were to say not account for their kidney function when I was giving them that dose, that could lead to life-threatening hyperkalemia and arrhythmias. Okay, but if it's the right drug for that patient based off of their disease state and based off of, say, maybe some survival benefits potentially, whatever the case may be, that may be a reasonable drug to give for those patients. We just know that it's more narrow. We know it's more dangerous. We'll take certain precautions to make sure that we're monitoring that patient effectively so that way they don't get into trouble. Okay. So, as I mentioned, we have narrow therapeutic index drugs. I'll show you a list of those in just a few minutes and just give you some clinical examples. You won't have to memorize the list. You'll kind of learn them as we go through the drug specifically, but I want to kind of start to acclimate you to how we sometimes therapeutically have to use these drugs, even though we know they're potentially dangerous, right? Now, again, what we can do in order to work with these narrow therapeutic index drugs is to monitor them effectively. Sometimes we monitor things like the blood levels of them. So for digoxin, we will measure digoxin levels to make sure that they're in the efficacious range, but not in the toxic range, right? For things like other drugs, we may use other monitoring parameters. So as an example, everyone is familiar with the drug Coumadin or warfarin. What kind of drug is that? It's a blood thinner, right? It's an anticoagulant. Well, obviously, that could be inherently very dangerous because if I give too big of a dose, what happens? They bleed out. If I give too low a dose, what can happen? Patient will clot up, right? It's no good, right? So they have AFib, they're at risk for stroke, things like that. So in those cases there, the toxic effects are directly linked to its therapeutic effects because that's what we're looking for. We want blood thinning effects, but not too much, right? We want to get right in that Goldilocks range. So in that case, what do we monitor? Well, we can actually monitor how well the blood is clotting by measuring PT-INR. If you get coagulation studies, that is one of the first things you'll get on there is you'll get APTT, you get PT-INR. That's what we're monitoring for with warfarin. So sometimes we have some surrogate markers there, but it all goes back to we know that they're inherently dangerous drugs. We have to monitor them to make sure they're in the right range, not too toxic.
Is there also a particular diet to follow in order to minimize the...
Yeah, warfarin, I could teach a whole elective on warfarin dosing and all of that. Fortunately, we're kind of getting away from warfarin with some of the newer drugs we have, but yeah, like vitamin K intake is super important for that, and genetics is really important, but for a good long time, I mean, for decades, that's all we had was warfarin. It's either that or nothing, essentially, right? Nowadays, you have some newer oral agents that are a little bit safer.
Another question, what is twofold difference?
Right, so again, if it's something where you've had less than a twofold difference in dose, that you could lead to some of these really toxic effects or potentially lethal effects there, right? So again, if I were to double the dose of the drug, that could lead to some big changes there, right? So again, if I doubled someone's digoxin dose all of a sudden, that could lead to some pretty severe toxic effects potentially. Yep. Okay, so just to give you some examples of narrow therapeutic index drugs here, some of these you may not be using clinically, some of them you will use pretty commonly. So as an example, a lot of drugs used as an antiepileptic, right, things we use for seizures can be considered narrow therapeutic index drugs because, how do you treat seizures, right? Well, what is a seizure? Seizures, your neurons firing off in a very uncoordinated sort of pattern. Well, I give drugs that slow that down. Well, what happens if I slow down the brain too much? Well, they get ataxic and they're likely to fall and they get sedated, right? So there's direct toxic effects that are linked to the therapeutic effects. So I have to monitor things like levels of phenytoin or phenobarbital or carbamazepine. I have to do all of that. Blood levels can be very useful to monitoring some drugs. Some other drugs may not be useful at all, depending on if we have good surrogates between the toxic effect and the therapeutic effect based on levels there. But just to give you an idea, we'll talk about more of these specifically when we get into Pharm 1 and Pharm 2 and when we come across these drugs again. Okay. Anyone know what you use lithium for? Bipolar disorder, yeah, used as a mood stabilizer. But this one has a very narrow therapeutic index, 0.6 and 1.2 milliequivalents per liter. So very small changes in dose can actually lead to some pretty toxic effects there, right? Because that range is so narrow. Digoxin 0.8 to 2 nanograms per ml, very, very small amounts. Small changes can make big differences. Okay, so again, looking at comparison between these therapeutic indexes, here's an example of warfarin, as we mentioned, is a fairly narrow therapeutic index drug because we know there's overlap between the desired effect versus the undesired effect, which in that case would be bleeding. Versus penicillin, we have a very wide therapeutic index. It's really hard to kill someone with penicillin unless they had a true allergy to it, right? Because it's a fairly safe drug. It's very specific for killing bacteria and not people, and thus you find it has a very wide therapeutic index. Now, sometimes we actually give things that have a narrow therapeutic index with the intention of killing off some of our own cells. You think of any cases of that? Chemotherapy, right? So again, we know that inherently that chemotherapy drugs are going to kill off healthy cells along with cancerous cells. So that would almost have, again, a very narrow therapeutic index there, but it's necessary because if we don't kill off the cancer cells will kill the person off. So again, you have your trade-offs there, right? So again, looking at summary of the curve, again, they can be graphed a number of ways. Normally, you're going to find that typically the x-axis is going to be on the log-based curve. That way, you can measure very big differences in doses between nanograms all the way up to grams of drug there. But again, it's trying to provide that critical information to allow for therapeutic decisions, right? Do I want to use this drug that has a narrow therapeutic index, or can I get away with using one that has a wider therapeutic index, right? As an example, look at drugs used for depression, right? Back in the day, we used to have to use drugs called tricyclic antidepressants. They were known to have a very narrow therapeutic index, and they were very likely to cause very severe side effects if you took too much of it. In fact, one of the things you'll find, I probably mentioned this last week, is that for depression, all of those drugs carry a black box warning. What is it? Increased risk of suicide. So you give these patients these TCAs, tricyclic antidepressants, and during that first couple of weeks there, you'd have them overdose on it, right? And it was very dangerous because it had such a narrow therapeutic index. Versus the SSRIs now, which is much more specific, they have a much wider therapeutic index than the TCAs. Someone can overdose on huge amounts of an SSRI and be relatively fine compared to someone who has a small overdose of TCAs. So again, these are the things we consider when you're trying to decide what drug to use for a patient, right? Okay, so why do people have variations in response? Why do some people have really good responses to drugs and other people have poor responses? And again, I don't say this in a derogatory fashion, but all your patients may be snowflakes to some degree, right? They may have little differences between them in terms of size of the patient, in terms of body habitus, in terms of genetics, in terms of all sorts of things that can affect how they're going to be responding to that drug, right? Some people say, oh, that drug really doesn't work for me. This other one did work better for me. Cases like that. Now, sometimes people use that for nefarious purposes. So if someone comes in and say, oh, I'm allergic to Toradol, I can't get anything, but Dilaudid works great for me. You may run into patients like that. Sometimes it may not be totally truthful, but sometimes people really do have variations in response, and so it's important to consider some of those things that may predict that, so that way you can try to head off some of those problems before they develop. So some of the things we're going to look at, we have things like idiosyncratic responses. We'll talk about tolerance and tachyphylaxis, and then hyper and hyporeactive responses. We'll talk about that in a little more detail here. So idiosyncratic responses are what we consider to be things that are rare or abnormal, right? They're not necessarily going to be able to be explained by the pharmacologic action of the drug itself, right? So these are things we cannot necessarily predict because they are pretty random. And again, with warfarin, we mentioned it's a blood thinner. You'd expect people to bleed, but sometimes you get really random side effects that occur in people that are not expected based off the fact that it works as an anticoagulant. So these are things you have to kind of consider there. These are not the same as an allergic response, right? Allergic responses are direct hypersensitivity reactions, which are kind of classified kind of by themselves. But just know that it cannot be reproduced regularly and with other patients, right? So just because I give this dose of this drug to a patient and they get a really weird response and I give it to someone else doesn't mean they're going to get that same response. So imagine, for an example, most of you have probably taken the drug Benadryl at some point in your life, right? Benadryl, anyone know what type of drug that is? antihistamine, right? So again, it's good for like allergies and things like that. Now, what's a common side effect of giving Benadryl? You get drowsy, right? So again, you probably don't want to take Benadryl before you come into my class, because otherwise they're going to be very synergistic. My dulcet tones and the Benadryl, you're going to be out for the count, right? Understood. However, some people, when you give them Benadryl, they have what we call a paradoxical response. It's a paradox because they get very excited. They get hyper agitated when they take Benadryl. Little kids can sometimes get this, to where you give them Benadryl because maybe they've got a cold and they're having a lot of postnasal drip and they're coughing a lot and they might throw up because of that. So you try to give them Benadryl. Now all of a sudden, instead of sleeping, they are hyper awake and they're running and bouncing off the walls, being terrors. It's happened, right? That's an idiosyncratic response that we cannot predict in those patients there, right? It's just something that may happen to some people, may not to others. Adults get this sometimes too. Some people, I just can't get Benadryl, it makes me crazy. That's exactly what's happening there. And it's hard to predict who will have that response. That's idiosyncratic. So another example would be something like the drug Primaquine. This is an old drug that we use for malaria. So again, not something we use a lot in the U.S., but we may use in patients who may be traveling to Africa, other places where malaria is more endemic. This can actually cause hemolytic anemia, but only patients who happen to have a G6PD deficiency. Again, don't get too mired down in the details of that, but it's basically an enzyme deficiency where they can't process the drug effectively, and it causes hemolysis of the blood cells. Now, again, could you test for G6PD deficiency beforehand? Yeah, but it's not common enough to where you need to do that routinely, right? Normally, people will have a reaction like this, and then you test them for it, and that's how you find that out. But it's important to know that some people may have this and you not even know about it. Okay, so again, that's more of an idiosyncratic sort of response, and again, not every patient will have that same reaction there. Okay. Now, talking about hypo or hyper-reactive responses here, basically this is where, again, you may find that the drug dose may not be the same as what you'd expect, or maybe a little bit more exaggerated, right? So again, as I mentioned, sometimes with Benadryl, you can actually have increased sedation. Some people are more sensitive to that response than others there. As an example, anyone heard of the drug Phenergan before? Promethazine is the generic name, but it's in the same class sort of as Benadryl, but it's a prescription-only product, used sometimes for vomiting, used for lots of different things. But one time I had a cold. This was before I was in pharmacy school, so I didn't realize this was illegal at the time. But my aunt was like, I was just feeling really miserable and just like runny nose just down my face, and I just felt terrible. My aunt was like, oh, here, try a Phenergan. And I said, okay, let me try this out. I've had Benadryl before, get a little sleepy, but not too bad. I took this Phenergan, and I was out for the next 10 hours. It's like the middle of the day, and I was out for that long. I woke up and I was like, what year is it? Oh my gosh. Everything was crusted over because I was just so dried out from the drug. But the thing was, I had this kind of hyperactive response to it because I was just so sedated from it, as compared to something like Benadryl, where I get a little sleepy, but not so bad. Another example of this could be something like opioid medications here. So there are some patients who have a polymorphism. Anyone know what a polymorphism is? Basically a change in one of their genes where they may either produce too much of it, too little of it. Maybe they have hyperactivity, less activity of the enzyme here. But when we get into metabolism of drugs, we'll talk about the CYP2D. We'll talk about the CYP enzyme system. It's really, really important for metabolizing drugs. Well, there's one specific CYP enzyme called 2D6. Now, one thing I'll talk about, and again, you don't have to memorize this exact example. I want to use it as an illustrative point. So imagine you have a patient who is a small child, and they have really enlarged tonsils, and they're having obstructive sleep apnea, right? So they're having a lot of snoring, and they're not really getting good sleep. And so you take them to the surgeon, or ENT doc, and they say, okay, I can go ahead and cut those things out, right? So you go in, you cut them out. Now, obviously, after the surgery, what's going to happen to that patient? Well, they're going to have pain. Also going to have swelling, right, because they just had surgery in the area there. So some patients we were giving a drug called codeine to. Ever heard of codeine? Codeine is an opioid analgesic, but what codeine does, it actually gets converted into morphine in the liver. That's where it has its actual therapeutic effect. So some patients would have hyperactive CYP2D6, so they'd be producing way too much of it, and they turn a lot of that codeine over into morphine. And we said one of the big side effects of morphine that's really deadly is the respiratory depression. So we're giving codeine to these little kids that had CYP2D6 in excessive amounts. They would convert a ton of this stuff over to morphine. They have these nice swollen airways, and they have respiratory depression at night when they're sleeping. I think they're sleeping comfortably, and then you go to wake them up, and they don't wake up. They're dead. So because there were several deaths associated with this for something we don't test for CYP2D6 enzyme expressiveness very often. So because of that, we said, well, you know what? It's just too dangerous. Let's just not use codeine at all. That we don't have to worry about it. So like at our formulary, we took it off. At Nemours, a lot of places just do not use it in children anymore because we cannot predict how someone might respond to that based off their polymorphism. Okay. So again, it's a difficult to predict sort of response. It is a hyperactive response in this case here. Okay. Now some people don't produce a whole lot of 2D6 and they don't convert much of that codeine into morphine. So what do you think happens to those patients? They don't have enough pain relief, right? They don't get that extra morphine kick. So like, this drug doesn't even work for me. This stuff's like nothing, right? So that's, again, you can find the pendulum kind of swings either way in those cases. Now, tolerance. What is tolerance? Yeah, so this is a thing that develops over time to a medication. So again, I go back to my example of alcohol. So imagine someone who is alcohol naive. Imagine all of you are, and you would have say 2 shots of say tequila. Say we're celebrating Cinco de Mayo, right? If you're alcohol naive, will that have an effect on the person? Yeah, probably 2 shots probably will have a decent effect on that person there, or maybe someone inebriated. Now, if I were to give that to someone who's a seasoned drinker, drinks day and night, what's that going to do to them? Nothing, right? They've become tolerant to the effects of that drug. Now, does that mean they cannot get drunk, clinically drunk? No, they can just have to drink a whole lot more of it. So that is the effect of tolerance. The body gets used to the effect of these drugs being around to where you need a bigger dose in order to get the same effects. So sometimes you'll have patients who have chronic pain issues, say chronic low back pain. They'll come to you and be like, man, this dose of this OxyContin just isn't working for me anymore. And you, if you're a jaded clinician, you may think, well, they're just drug seeking. That's not legitimate. But they could actually have developed tolerance to that drug, and they legitimately need a bigger dose in order to get the same analgesia that they were getting before. So that is something to consider, is like how patients develop tolerance to the effects of these drugs.
Can like the tolerance change? Like say if you took a medication when you were like younger and then like you had this high tolerance for it, and like years later you could take it again, does the tolerance ever like go down again?
Yes.
Okay.
Yeah, so this goes back to that idea of up and down regulation of receptors, right? So again, if you took it earlier on, say several years ago, and you developed a tolerance to it, that will dissipate over time because you haven't been challenged with the drug, and then when you go back to it, that's actually a big problem we ran into with opioid addicted patients, where they would be taking a normal dose of heroin, right? For them, they've kind of worked up to a certain dose. They would go to rehab where they try to cut them off cold turkey, right? They would eventually leave rehab, go back to their normal dose of heroin, and guess what? That was too much for them now because they were not as tolerant as they were before. That's they get respiratory depression, they die. So that is something to consider there as well, is that you lose that tolerance over time in a lot of cases.
How are you like supposed to determine whether they are drug seeking or whether they actually have built up the tolerance and need more?
Boy, if I had a perfect answer for you, I'd be a rich man. It's hard to tell, right? Some cases patients are very good at lying and faking symptoms. There's some certain ways we can do that now. We now have what we call eForce, which is a prescription monitoring program that we can actually use to monitor to see where patients have been filling narcotic scripts in the state of Florida. That's been very helpful to help try to determine that. So if you have a patient comes in and is like, oh, I'm just in a lot of pain, my back hurts, can you give me anything? And you come and be like, yeah, well, you feel like 200 OxyContin just the other week. Where did all those go? Yeah. You bring the printout. Usually they're like, never mind, I'm good. I forgot about those. My dog ate them. Is your dog okay? Yeah, he's fine. Really? Okay. So it's tough, right? It's very difficult. We had one patient, an adult patient who was in the peds ER and complaining of a pain from a kidney stone, and the UA had blood in it, right? So it looks like they might have had a kidney stone, but they can prick their finger and put blood into it. When you looked at the eForce, they've been filling it all over the place. So it is easy to become jaded, but just remember, some people really do have legitimate pain complaints, right? Because sometimes pain changes over time. Sometimes they may have aggravated it based on some new activity or whatever the case may be. So again, try to keep your empathy up a little bit, at least for now. Wait till you get in rotations and become jaded.
Control that because it cannot keep going up, right?
So in some cases you can, right? So you may find, as an example, so imagine you have a patient who has end-stage cancer and they're having just terrible pain, like and lung cancer or something like that, and they're in awful pain from all these metastases everywhere. We can go up very, very high dose, especially in palliative care, where it's okay if they're getting some of those toxicities because like respiratory depression, because it's okay, they're in palliative care. Like we understand we're trying to increase the quality of life, not quantity of life at that point. So in some cases you can keep driving up the dose of the drug. In some cases you may not be able to get much additional effect. You may have to add on maybe another medication to help out with that. A good example of that is something like diuretics. Diuretics normally help us to do what? Pee, right? The pee more, you get rid of fluid. Sometimes you can develop resistance to one type of diuretic. By adding on another one, you can kind of overcome some of that tolerance, and then you have a lot greater effect and you start to pee more again, right? So there's different ways to get around it. We'll talk about those strategies as we get to them in individual examples. But But again, oftentimes, we develop tolerance to a lot of the things we may be exposed to on a chronic basis. So, is anyone here abusing caffeine potentially? Maybe not abusing, but maybe utilizing caffeine. Now, imagine you might be using it on a daily basis. If I were to, say, give you an extra cup of coffee, do you think you'd have much of an effect on you? Probably not, right? I'm familiar with the... To make you happy, yeah, exactly. It may help you get a little bit extra of that, dopamine rush, a little bit, but you probably would not feel jittery. You wouldn't be up all night, right? Because again, you're so tolerant to the effects of caffeine, right? My blood is laden with caffeine at any given point, to where basically this is just keeping me normal, right? Very tolerant to the effects. However, you were to take it away, all of a sudden, what would happen? Rebound headache, you feel miserable, like it's no good, right? So sometimes you got to keep that up, otherwise you can have those withdrawal effects. But tolerance is basically that, right? So, but imagine you went cold turkey for a while. You say, you know what, I graduated PA school finally, thank goodness. Go away without caffeine for say 6 months, and then you were to re-challenge yourself with a big cup of coffee, venti cold brew from Starbucks. You'd be probably up all night, right? Because again, you'd lose some of that tolerance. Okay, so again, that's kind of what we're talking about. Again, by challenging it with a bigger dose, sometimes you can overcome that. Sometimes we may need multiple drugs in order to get around those sorts of things there. Okay. The tachyphylaxis is sort of different than tolerance, and this is actually where the body is unable to generate any more of a response to a drug, even though you keep driving up the dose. And so the good example for this one is called nitroglycerin for angina, for chest pain. If you ever look at long-acting forms of nitroglycerin, say like a nitro paste, right? It's a transdermal product we'll use for some patients. They'll say, we'll put it on for 12 hours, and then you leave them off for 12 hours. So why only 12 hours? Like, what if I have chest pain in the middle of the night? Well, the reason why we do that 12 hours on, 12 hours off is because this case called tachyphylaxis. Sometimes by having a drug in the body, you may find that the cells lose the ability to even have that response to that drug, right? So eventually you're going to lose cofactors, you're going to deplete certain factors in the cells to where you lose that response to the drug. So if I had someone that I was giving nitroglycerin to on a chronic basis, say 24 hours a day, eventually you would start to lose that effect. Even if I increase the dose of nitroglycerin, I would see no increase in that smooth muscle relaxation, okay? And in order to get the effect back, I have to take away that drug for, say, a 12-hour period, and then they can get it back again once the cells have kind of gone back to normal.
More like a quick, more like a short term?
Well, tolerance is something that I can overcome with bigger doses, right? So again, if you, I can give you enough caffeine to eventually get some effect out of you, right? So again, it's all a matter of overcoming it with a bigger dose. With this, it doesn't matter how much I drive up that dose, I can't get any more response out of it. It's a rare phenomenon, but it is something that's important when you see things like only give it for 12 hours on, 12 hours off, right? Or something like that, because you need the body, you need to give it time in order to kind of get back to baseline before I can give you that drug again. So again, in the case of like chest pain, like when are people most likely to have chest pain? On exertion, right? When are you exerting yourself most often? Daytime or nighttime? Well, daytime, right? So again, typically we'll give those patients nitroglycerin, that paste, during the daytime when they're more likely to be exerting themselves, and we'll leave it off at nighttime when they're more likely to be sleeping and not exerting themselves, right? Or if they work night shifts, maybe we'll flip it, right? So it just depends on the patient and kind of what their setting is. Okay.
Is that true for all those other patches like fentanyl?
No. So that is only the transdermal nitroglycerin that has that effect there. Other drugs can be given continuously via the transdermal route, and they have no problems with that. It's not a factor of the transdermal route by any means. It's just a matter of the drug and how it works with the cells. Yep. Okay. Let's see. Other things you can see, like amphetamines, this is another common one. So amphetamines, what do we use those for? ADHD. So clinically, oftentimes people can abuse those for euphoric sort of purposes. You'll actually find that stimulates release of neurotransmitters like epinephrine and norepinephrine, dopamine, things like that. Well, if I cause that to keep releasing all those catecholamines and all those neurotransmitters, eventually those cells run out. And so even if I kept giving more amphetamines, guess what? I don't see any additional effect until I give the body time to regenerate those neurotransmitters. Okay. So again, just another example. Again, don't memorize the specific examples, but the concept is what I want you to get, right? So again, so I give you the examples to try to link those in your mind together. Okay, and again, why can we have these variations of response? Okay, well, one could be an alteration in the drug concentration that actually makes it to the receptor. It could be a variation in some of the endogenous ligands that we're producing ourselves. It could be due to the number or the function of the receptors, or it could be due to change in some of the downstream components. Okay, that means what are the secondary, tertiary effects that happen downstream from initially that drug kicking in at the receptor. Okay, so we'll talk about these in a second. So what are some ways that we can alter the drug concentration that reaches the receptor, right? These are usually going to be pharmacokinetic issues. That's what we're going to talk about for the majority of next class session here. So again, if we change the absorption, the distribution, the metabolism, or the excretion, that can change how much drug actually gets to the target tissue. So as an example, what if I have upregulation of hepatic enzymes? Is a drug called carbamazepine that we use for either seizures or we use as a mood stabilizer for bipolar disorder. And so what you actually find is it induces its own metabolism. It actually causes the enzymes that metabolize it to ramp up in number. That means that as that ramp up occurs, it's metabolizing more quickly. That means less of that drug gets to the tissue, which means the drug may be effective initially, but then the effect starts to go down. You're like, well, why is the patient not responding anymore? Well, it's because now they're metabolizing more of it, not as much as getting to the tissues. Well, how do I overcome that? Well, give more of the drug, yeah. So you actually find there's a dosing strategy where you'll start off at this dose for week 1, and then week 2 you go up to this dose, and then week 3 and week 4, and eventually there's a homeostasis point that hits where that is the effective dose for that patient now, right? Again, you're overcoming that the upregulation of those enzymes. Again, not super common, but if you ever see that dosing strategy, that's what we're doing. We're trying to ramp them up to overcome that to make sure that we're getting the right amount of drug to those tissues. Okay. It's not the patient really needed that much more drug at the tissue site. It's just that we were getting less of it there in the first place. Okay. Other things can affect this as well. Gender, age, weight, things that affect how much adipose tissue you have or how little you have. Different disease states can affect this. All of it can change how much drug is really getting to the receptor sites. And we'll talk about those more specifically when we get to those examples in Pharm 1 and Pharm 2. Other things as well, you can have things like multi-drug resistance transporters. These are actually responsible for shooting drugs out of cells or say out of the CNS or back into the GI tract. These are really important. So has anyone ever heard of grapefruit juice interacting with medications? It's don't drink grapefruit juice with this drug, right? Certain cholesterol drugs are really notorious for this one. And now, who drinks a lot of grapefruit juice? You love it? Oh, you're sort of the outlier there. Who else normally likes it? Yeah, old people, right? Because again, their taste buds are going out, and they need something strong to really kind of kick their taste buds into action. That's how my grandpa grew a big grapefruit tree, and that's they love this stuff. And I was like, this is disgusting. Now we have like 40,000 grapefruits, and no one wants to eat it but you. But anyway. But they love the stuff, right? However, it interacts with some of his medications because what it actually does is it inhibits this multi-drug resistant protein. So instead of shooting some of that drug out of the body into the GI tract, he was absorbing much more of it because that protein wasn't working. That means the levels of that drug would go up, and that could lead to what? Toxicity, right? Higher levels mean more likely to see side effects. That's why you would say don't drink this with grapefruit juice because we know the levels will go up and can lead to things like liver damage, muscle damage, things like that, right? So these are the reasons why we have some of these warnings with these drugs is because of these differences in things like transporter activity, enzyme activity, etc. Okay. I'll talk more about those multi-drug resistant proteins later on when we actually get into the pharmacokinetic section. Now, how about the variation in endogenous ligand concentration? So we have a drug called propranolol, which is a beta blocker, right? So beta blockers block the beta receptors, okay? What normally activates beta receptors? Talked about it a little bit earlier. Epinephrine, norepinephrine, right? That fight or flight response there. Now, what this will do is help to slow down the heart rate, especially when you have high amounts of catecholamines around, right? So imagine, for example, I were to say, hey, one of you come up here and give the rest of this lecture. Now, what would your response be? Yeah, you'd say no first, but I said, no, you have to do it. Otherwise, you get an F for the whole class, and you fail out of PA school. You'd probably come up here and give it at that point, right? You wouldn't be very happy about it. Your fight or flight response would be kicking up. I imagine some of you have already, I can see some of that response in you already, right? Pupils are dilating, sweat starting to come down your forehead. So that's that fight or flight response. So say, for instance, I gave you a beta blocker to block some of those effects. Well, instead of being tachycardic, your heart rate would kind of be somewhat in the normal range. You may not have that much tremors. That's why we give a beta blocker for stage fright, because it helps to deal with some of those fight or flight responses there. It makes it easier to get these presentations. However, if you were to take it as a normal resting level, when you don't have a whole lot of those catecholamines flying around, when you're sitting there passively listening to a lecture, the beta blocker wouldn't really do a whole lot for you because, again, you don't have a lot of that epinephrine interacting with those receptors. That kind of makes sense? It's only really working when it needs to work, when you're actively having that fight or flight response, okay? Anyway, so that would be a case where the endogenous ligand concentration or the catecholamines like epi and norepi would actually be varying concentration based on the clinical setting. So other things that can come into play, things like altering the number or the function of receptors. So obviously, if I have an agonist that I'm giving, but I reduce the number of receptors available, what does that do to my efficacy? It's going to go down because there's less receptors for it to interact with. Versus if I were to increase the number of receptors, you see an increase in the efficacy, right? And again, this is where we see a lot of the up and down regulation playing a role here. You can also find that hormones can have a big role to play in altering the actual expression of these receptors as well. So if you imagine someone who's hypothyroidism, what do they kind of look like? Are like full of energy and jumping around, having a good time? They're slow, having kind of depressed, right? And that could be due to the fact that they don't have enough thyroid hormone, thyroxine, actually causing these receptors to be upregulated, right? Now, someone who has hyperthyroidism, they have too much thyroid hormone around. What do they look like? Sweaty, they get hypertensive, they have a lot of energy, their metabolism's up. That is due to the fact that you have a lot more of those beta receptors and alpha receptors are now being expressed because of that hormone there. And that means that sometimes they can have things like thyroid storm or thyroid toxicosis that can develop because of that, because now they have more expression of those receptors there, right? So again, that can alter how well someone's going to be responding to certain drugs, as the case may be. Okay. And again, I may find that things like tachyphylaxis intolerance can actually reduce the number of those functioning receptors because it's usually in response to those agonists that are being constantly activating it, causing a downregulation. Okay. Sometimes you can have desensitization of the receptors themselves by constantly activating them, overstimulating them. You'll find that they become decreasing in responsiveness. And so the reason why our cells do this is to try to prevent damage. By being overly activated, by getting too much stimulation, that can actually lead to cell damage over the long run. And so to try to inhibit that, cells will then desensitize. So that's one thing you may see. A good example of this, there's a paralytic called succinylcholine. If anyone like EMS experience, you probably are familiar with succinylcholine. We give it when we're trying to intubate somebody. It's what we call a depolarizing neuromuscular blocker. What it actually does is it will go and activate your skeletal muscles, and it'll overstimulate them to the point where they want to desensitize, and then they'll stop working altogether, and then you become paralyzed. So initially they call it depolarizing because you initially will see actually the patient kind of twitch because they're having these fasciculations from activating the muscles, and then they'll stop. Because now the receptors are desensitized, and now they're not working at all, and now they're paralyzed, and you can get them intubated, right? So again, just an example of how that can occur potentially. Again, you can find is that in this case here, when you have diminished response to those drugs due to that desensitization, that is considered to be that tachyphylaxis. By reducing the amount of drug or by taking away completely, you'll get back to that baseline over a period of time, and then by reintroducing the drug, you'll get more effect out of it, okay? And again, just to give you an example of what this looks like, imagine if I were to give you a repeated dose of a drug over time, you can see here that the effect will diminish, but once I give it a break, give the cells a chance to get back to normal, then you'll find they have the same effect as it did before. Okay, this is sometimes what we call a refractory or an unresponsive sort of period. Again, time will help to fix that, get cells back to their baseline. Now, sometimes we can have what we call the rebound phenomenon. I think I might have talked about this before, but this is an example where by altering the number and function of those receptors, you can sometimes have a really exaggerated response that happens as a result of that. So imagine I were to give a patient a beta blocker. I'm blocking the beta 1 receptors on the heart. That will slow down the heart rate and will lower the blood pressure. Okay. Well, in response to that antagonist, is blocking those receptors, we'll have our receptors do what? They'll upregulate in order to try to get back to normal homeostasis. And then we give, that drug will still then interact with those new receptors and everything will be fine. However, if you were to abruptly withdraw that drug, now all of a sudden you have way more receptors available. It's going to interact with our normal catecholamines like epi and norepi, and thus you're going to find you have a really exaggerated over response that happens there where they can have increased heart rate and blood pressure. So as an example here, imagine our little green triangles here are epinephrine, here are the receptors on the myocardium, and then here's the actual myocardium itself. And normally it would interact and everything's fine. Heart rate say 75, BP 145/90. Okay, it's a hypertensive patient. And now let's say we give a beta blocker and we get their heart rate down a little bit, and then the blood pressure say 120/80. So everything's good, right? Everything is as it should be. But the cell here is saying, oh, wait a second, I don't have enough receptors here. These are not being activated enough. This is odd, right? So let me go ahead and try to get back to normal. And I'll say, well, let me get more receptors available. This is upregulation happening here, right? I have more receptors at the cell surface. Okay, so everything looks fine now. However, what if I then take away that beta blocker and now I have all these extra receptors getting hit with all this epinephrine? Now what happens? You get a rebound phenomenon. You get the heart rate going up, the blood pressure is higher than what it was before. because now the heart is even more responsive to those catecholamines. And what can that induce? Now the heart's working way harder, maybe it has a hard time getting oxygen to the heart, and then it can cause ischemia, it can cause a heart attack. There's actually been cases where patients have had a heart attack due to that abrupt withdrawal of a beta blocker or something like that. Okay, so again, have to be careful with some of these drugs in terms of that abrupt discontinuation that can lead to some really bad rebound or withdrawal phenomenons. Okay. So again, other things, change in components of the response distal to the receptor. Oh, yes, sir.
Is that why, like, sometimes when you're dosing, like, the first dose is way stronger and then you kind of move off a little bit?
No, sometimes it's called what we call a loading dose, or sometimes we'll give a bigger dose to try to get your levels up, and then we'll give you smaller doses to keep you at that level. And we'll talk much more about that when we get into the kinetic section. So keep that in the back of your mind. But yeah, that would be a little different than what we're talking about with that. That would just be if you're giving a drug continuously and then you are on a chronic period of time and you take it away and you see that kind of over-exaggerated response back to it. Yeah. Okay, so anyway, so we can have sometimes some downstream responses, so things that may be distal to the actual effect of the drug itself. So imagine, and you guys are familiar with the renin-angiotensin system? You've heard of that before? Right? Anyone know what that does? Helps regulate your blood pressure, right? And is mediated through the kidneys. Kidneys release renin when they detect low pressure or low salt or low volume, and they cause blood pressure to go up, okay, when they detect that. Because again, kidneys want to keep themselves perfused pretty well. So imagine I were to give a beta blocker to a patient and I were to get their blood pressure down, okay? So blood pressure is below what their normal is. The kidneys will then respond to that. They'll say, wait a second, pressure's not high enough here. Let me go ahead and respond by releasing more renin, and then they'll try to get the blood pressure back up. So you can see how the body's trying to fight the actions of the drug to try to maintain that homeostasis there. And so that's why in some cases I can get over that by increasing the dose of the drug, or I can try to get around it by adding another drug onto that, maybe something that affects that renin-angiotensin system. If you're not familiar with it, we're going to talk about it extensively when we get into the blood pressure section, so don't worry about that. We'll talk a lot about that. You'll be very familiar with that RAS system later on. But again, the body has a lot of compensatory mechanisms to try to get back to homeostasis, and that sometimes can make it so that you have to increase the dose of drug or maybe sometimes add on something else to overcome that. Okay, and again, looking at clinical selectivity, so the beneficial versus toxic effects, it's important to understand that sometimes drugs can interact with multiple types of receptors, some of which may be beneficial to the thing you're trying to treat. Sometimes it may be completely separate from what you're trying to treat and lead to side effects, right? We'll talk more about side effects later on, but you may find that it can lead to a lot of the issues that can happen about with these drugs here. And again, if you're thinking about selectivity, think about the example of, say, chemotherapeutic drugs versus antibiotics. Now, antibiotics are relatively safe for people because ideally we'd be targeting the bacteria, and thus they have different targets than human cells do, and this is relatively selective, right? You still get side effects from antibiotics, but they're not nearly as severe as something like chemotherapeutic drugs, which target human cells as well, right? They're going to kill a lot of healthy cells and cancer cells. So because of that, they have relatively low selectivity, and because they're that you're going to see a ton of side effects, right? When you think chemo drugs, what kind of side effects do you think about? Alopecia, you think about nausea, vomiting, you think about immunosuppression. I mean, like, they're really, really nasty drugs versus antibiotics, like maybe some stomach upset, maybe some diarrhea. They're relatively selective, and thus they are going to have less side effects in terms of overall safety and toxicity there. So again, ideally we like highly selective drugs, although we may not be able to get away with that. That goes back to why when I was talking about antidepressants, TCAs or tricyclic antidepressants versus SSRIs, TCAs were not selective at all. They affected all kinds of different receptors, and this led them to be very dangerous in overdose. SSRIs work very, very specifically just to block reuptake of serotonin, because of they are much, much safer, right? They're much wider therapeutic index than something like a TCA does. Okay. And again, you can look at selectivity by measuring the ED50s and then comparing them together. But again, when we're looking at that selectivity, it's mostly going to come down to how do we measure out the therapeutic effects versus the toxic effects we're going to be seeing thereof, right? And again, whenever you give a drug to a patient, you have to think about the risk versus the benefits. And that's essentially what you're looking at. It's the therapeutic effect versus the toxic effect there, and seeing, okay, well, do the therapeutic effects outweigh the side effects? If so, then yes, this might be a good drug for the patient. If not, maybe it's not so good. And again, sometimes you can actually find that the side effects are mediated through the same receptor activity as the therapeutic effects. So going back to our example of warfarin or Coumadin, as we said, that is a blood thinner, right? So it causes the blood to be less likely to clot, which is good if you were in a stage where forming a clot would be bad, like if you have AFib or something like that, or more likely to form a clot. However, if I were to drive that dose up, eventually you see what side effect? bleeding, right? So again, that's mediated through the same exact activity, right? Think about insulin. Insulin's used to get blood sugar down. If I give too much insulin, you get hypoglycemia, right? So that's all mediated through the same activity there, right? And that's why we have to monitor the doses that we're giving. We're monitoring things like blood sugar or INR because we know that the therapeutic effect is synonymous with the toxic effect there, okay? Sometimes you may find that they happen through different tissues or different receptors. So as an example, if I have someone who, say I have a patient who has COPD and they have diabetes, and I give them, they're coming in with a COPD exacerbation, and I give them prednisone, I give them a corticosteroid to deal with that inflammation. Well, if they have diabetes, guess what else is going to happen? I'm going to get increased blood sugar because that's just a different effect that the corticosteroids have because they have a wide range of activities, not just in specifically treating COPD. Now, sometimes I can get around that by giving very route-specific or tissue-specific means of delivering those drugs. So as an example, well, instead of giving an oral steroid that affects the entire body, what if I just gave an inhaled steroid that affects the lungs? Sometimes you can get around some side effects when you do that there, right? Other things you can see, the steroids, you can see fluid retention that may be bad for CHF patients, lots of things you can see with that. In some cases there, we can also get around side effects by using the lowest effective dose. That's always the ideal thing to do, is the lowest dose possible is going to be good there. Or if we can use a drug with an alternative mechanism that may be beneficial too, right? So if avoiding steroids altogether may be an ideal thing for that particular patient. Okay. And again, looking at this, you can find that sometimes the toxic effects are mediated by different types of receptors. So as an example, we talked about epinephrine, how that can lead to effects on alpha, beta, and other types of receptors. And so sometimes that can lead to different clinical effects depending on the setting there. As I mentioned, epinephrine can be used to help to increase heart rate, can be used to increase blood pressure in cases. They can also lead to other side effects such as constricting blood vessels too much to cause ischemia, say in the GI tract, right? So again, it's all mediated through the same mechanisms there, but just different receptor types. And then sometimes by making drugs more selective, you're able to eliminate some of the toxic effects while being able to keep around the beneficial effects we're really looking for. So we'll talk about things like NSAIDs. NSAIDs are known to cause a lot of gastric ulcers and things like that, but by selecting out for a particular enzyme, you can try to mitigate that risk as one example. Or for instance, looking at histamine blockers, separating out H1 versus H2 blockers, right? And we'll talk more about those later on. But these are just ways we can try to be more selective in order to get just a therapeutic effect while trying to limit some of that toxic effect. Sometimes we can actually get new therapeutic effects from drugs that cause a side effect. So everyone's familiar with the drug minoxidil or Rogaine. Rogaine does what? Causes you to grow hair back, right? So this is actually originally used as an antihypertensive. We used it and we actually found that it's really kind of crummy as an antihypertensive, but we noticed that patients who were taking it were getting hypertrichosis, right? They're getting hair growth. So what if we just rub this on their heads? All of a sudden it worked. So again, that was something that was originally used for a different purpose, but we use that side effect for the intended effect. Or anyone from, oh yes ma'am. Topiramate, for which indication would you be referring to?
I thought it was originally procedures.
Mm-hmm.
Then it helps with migraines.
Yes, yeah. So that could be one thing where we found that there's an additional benefit to using topiramate. So again, that's one that has a lot of different indications based off its multiple actions that it has there. That's a little bit different because this is actually like a side effect that we're turning into a therapeutic effect. That's like an additional it's kind of kismet, like okay, wow, it also works for this too. Great, that sort of thing there. But there's another good example. So anyone familiar with the drug Latisse? So it's something that is used for cosmetic purposes. Latisse will actually help to grow your eyelashes. Well, that was a side effect that we noticed when we were using it for patients who had glaucoma. We're giving them that same drug in their eyes, and they notice, wow, they have such long, luscious lashes now. Let's use this for therapeutic or for cosmetic purposes, and now you have Latisse you can use there. But so again, just other examples where we can get kind of these happenstance sort of things we see that, and we can use them for different purposes. Anyway, so again, whenever possible, we always try to shoot for things that are more selective than less, because that's going to help to cut down on some of those kind of ancillary side effects when possible. And again, just know that when looking at potency or efficacy, they need to be taken into the clinical context in terms of, okay, well, what else is going on with this patient? What other side effects can I expect to see? And trying to mitigate those in order to determine what's going to be best for that particular patient there. All right, so any questions? There's a lot of stuff. I think we got through most of it. Okay.
Is it possible to have how the lethal dose is usually to the extreme?
It should be to the right, yep.
The TD and the LD reverse?
Probably not, because your patient's dead. They're unlikely to have a side effect, right? So, yeah, no, I mean, I guess it would depend on the particular TD50, but not typically. Normally, you're selecting what that TD50 is, like if it or it's low blood pressure, or whether it's whatever the case may be, and so typically be to the right of the therapeutic effect. Sometimes you may have side effects that happen before you get a therapeutic effect, right? You can see that a TD50 may be to the left of the ED50, potentially, but that's not super common. You would see that.
Pharmaceutical companies have to use the
It's
they have to use a therapeutic index using LD.
They'll either use that or the TD50. You could use either one.
Because if you use a TD50,
yeah, it may look lower, but again, you have to take into context. So you say, well, okay, what did you use to get this therapeutic index? You say, oh, I use LD50 or I use TD50. You kind of specify that. Okay. Hold on, guys. Let me look at the sticky board real quick. See if there's any questions. Okay, is tachyphylaxis in response to receptors being unavailable for more drug to bind to? Not necessarily unavailable. They may still be there, but the downstream sort of intracellular like cofactors and enzymes and things like that may not be available. The receptors are usually still there in those cases. That answers your question. If nothing else, yes, ma'am.
These are recorded, correct?
Yeah, these are all recorded. Yeah, I'll post it up.
I'm not seeing that the options are on YouTube.
Yeah, so if you look on Canvas, there'll be a link under the PowerPoint. If you click on that, it'll take you to a YouTube, and you should be able to watch it from there.
I sent the link in the group.
Yes, ma'am.
So for the tachyphylaxis,
Uh-huh.
so the receptors are still available and the drugs are binding, it's just not having an effect.
Exactly.
They're not even binding.
No, they're still binding. Yeah, it just may not have much of an effect when it does bind, which is why I can keep giving more and more drug. You just really won't see any additional effect out of it.
So is tolerance and downregulation synonymous?
You may see that to some degree. You may find that it's a component of the tolerance there. Yeah, for sure. Okay. So the test next week, right? People probably want to know about that, right? I assume. Okay, it's going to be 25 questions, so it's kind of like a glorified quiz, right, so to speak, if that eases your mind at all. It will be a lot of definitions. It'll be a lot of the concepts we've talked about so far. It'll go up through this section here, so please study up on that. I know it sounds like your week is pretty well compacted, Monday through Wednesday. I apologize for that, but it is what it is. We have class on Wednesday, so you'll take your test, and then we'll have class afterwards, and then I will go through the test, see if there's any give backs, see if there's any high misses or anything like that. If you have any concerns or anything, please let me know. If you have any questions before the test, email me earlier, right? I like to be responsive to you guys and get back to you, but if it's like 1 o'clock on Tuesday night, I'm probably not going to get back to you, right? Like, it's just the way it is. I'm probably asleep by then. Usually it'll be a multiple choice. It'll be 5 answer choices, pretty typical. We'll figure out the timing with, it'll at least be one question per minute, no less than that for sure. Any other questions? Probably be on ExamSoft. It's pretty straightforward. Yeah, this will be, again, these are not going to be the kind of mind-bending sort of questions you'll find on Farm 1 and Farm 2, where it's like, here's your vignette, here's your patient, decide which drug is best for this indication, right? Or, what's the right dose for this patient? It's more going to be, which of these is the definition for toxicology, or something like that, right? So, and it may be things like, which one would be the safest based on ED50 and TD50, or which one's most potent based on the ED50, like things like that you should be able to recognize, okay? So pretty straightforward. Don't get too scared by it. It'll be fine, right? A little bit of stress is good. Too much stress is counterproductive. Yes, sir. It'll be due not next Friday. It'll be due the following Friday. Yeah, not on July 5th or whatever. It'll be the following week. Yep. Yeah. Look at your syllabus and you'll find all the due dates on there. Yep. I'll try to grade your stuff over the weekend. All right. Thanks.